Well, Stephen, ladies and gentlemen, thank you very much. It's indeed a great honour to be invited to give an award lecture for the clinical science course at the IDF. And I'm hugely grateful to the IDF committee for having this opportunity of talking to you and also visiting Vancouver and this beautiful city. So the title I have for you today is Sweet and Low, How Hypoglycemia Research Might Address the Diabetes Pandemic. And I don't know how to move my slides. Left, right. Got it? Okay. Yes. Good, we're winning. I have no conflicts of interest to declare because for the last 3 years I've been working for the UK's National Institute of Clinical Excellence with a guideline development group for the guideline for adults in the UK with type 1 diabetes. And what I'd like to talk to you today about are pathways, because this is an award lecture, and what I want to do is talk about patient pathways, because whatever we do always comes back to the patient's needs. Career pathways, namely my own, and how I got to where I'm going to be in the story I'm going to tell you. And finally, neural pathways, because as Steve indicated, we have become very interested in the brain's role in controlling metabolism. And there are, in diabetes therapies today, to my mind, two great challenges, and they're really opposite ends of the spectrum. So hypoglycemia in diabetes treatments is a huge problem, and that's really where I started my research, as Steve has indicated. And here you see the low of the sweet and low in the title, and here you see the sweets. These are the 5 Barrett's jelly babies. If they're not Barrett's, you need more of them to treat your hypoglycemia. And that's fine, because that's very useful, but of course if you eat too many of them, and particularly if you add to it other unhealthy things and you eat a lot, then you develop obesity and type 2 diabetes, which, if you like, is the complete opposite end of the spectrum, and you may wonder how you can put the two together in a single research program. But if we could crack these two ends of the problems confronting our patients, we would be in good shape. So let's start where I started with my research interests in hypoglycemia. Just to start, as one should, with a definition. What do we mean by hypoglycemia? Well, if we translate directly from the Greek, we are talking about under or beneath a normal, brackets are mine, glucose in blood as a direct translation. And the Collins Medical Dictionary helpfully says to us that in medicine, hypo is denoting a deficiency or an abnormal low level. Now, the reason for mentioning that is because at the moment there is big debate about what that number should be. We had a discussion in a meeting this morning. There are more discussions through the IDF program this week. But essentially, if we look at the data in the literature, then a normal fasting glucose or blood glucose is the lowest limit, is between 3.3 and 3.5. So I think we can agree that technically hypoglycemia is under 3.5 millimole per litre. But we'll look at the significance of different definitions for hypoglycemia as we proceed. Now, in health, hypoglycemia doesn't happen. So in spite of huge differences in the amount of energy we expend in sleeping or exercising, in fasting or eating, our plasma glucose remains pretty stable throughout the 24 hours and throughout the week. And it does that because we have enormous capacity to alter our insulin secretion in response to need. And so this a study from Ken Polonsky's lab shows you what happens to insulin levels over the 24 hours in a person eating 3 meals a day, a group of people eating 3 meals a day, huge variation over very short spaces of time. And if you're obese and insulin resistant, those variations are even larger. But because of that variation and because of anti-insulin processes in the body, our blood glucose remains very stable, and it's only when you try and replace missing endogenous insulin that you really start to have problems with hypoglycemia, and your curves can end up looking more like this. And we've known that from within a very short time of the discovery of insulin in 1921. This is a paper from Banting's own laboratory where he describes the first hypoglycemias induced by therapeutic insulin in a group of 50 patients who were the first people to receive his insulin preparation in this country. And what you see is that they noted hypoglycemia with a blood sugar. Remember, the measurement of blood sugar in those days tended to err on the high side, but that was 73 milligrams per deciliter. And he further noted that at different glucose levels, you would get different manifestations of the hypoglycemia. And in passing, it's interesting to note that in all the time that has since passed, we are still treating it with 50 to 100 cc's of orange juice or 5 to 25 grams of glucose, so there's really nothing new under the sun. Interestingly, if someone was comatose, he gave them adrenaline before giving the glucose. One of the comments he made that is no longer true is that he said very distinctly that once a patient has had a reaction, he is quick to recognize the onset of the next one, and that is the patient's best defense against severe hypoglycemia where the patient is so incapacitated they can't self-treat. Now, jumping on 60 years or so, we come to 1978, and that wasn't just the year I entered diabetes as a career, but that was, in a sense, the birth of the modern insulin era. And this is Guy's Hospital, where I trained, and in 1978, a team comprising Harry Keane, George Alberti, and John Pickup created the British version of the continuous subcutaneous insulin infusion, the insulin pump, and at the same time, Bill Tamberlane and Bob Sherwin, that's the British version, Bill Tamberlane and Bob Sherwin were working on an insulin pump also. And the two groups got together and did the first study of randomized controlled trial of intensive therapy. It was designed as a forerunner to the now famous DCCT. It was the CROC study, and basically showed that if you randomized people to tight control using pump therapy, A, that it could be done, and B, that after a period of time, it may have some benefit on retinopathy. And if you like, that was the midwife or the progenitor of the definitive trial, the Diabetes Control and Complications trial. And then this slide is going to be very familiar to the whole audience. Here we show the benefits of prospectively randomly allocated intensified diabetes therapy on retinopathy. This shows you that the lower the glycated hemoglobin, the lower the risk of retinopathy, and in later follow-up, lower risk of macrovascular disease and even premature mortality. But at that time, associated with an increased risk of severe hypoglycemia, and a particularly increased risk of severe hypoglycemia at any given degree of glycated hemoglobin if you were using intensified insulin therapy as practiced in the 1980s. So about that time, I went from the UK to Yale, and already the group had started to investigate counter-regulation to hypoglycemia in the intensively treated patients, because it was clear that they appeared to be tolerating hypoglycemia, being comfortable at lower glucose levels than we were accustomed to seeing. And the first study we did was to show that when you just gave a low-dose insulin infusion to people in tight control of their diabetes or people who had conventionally treated, not very well-controlled diabetes, there was a big difference in the glucose level that they would reach. And what we needed was a glucose challenge that we could apply in a very reproducible way in order to compare responses between treatments, between patients, and over time. And working with Bill Tamberlane, Bob Sherwin, and Ralph DeFronzo, we developed the stepped hypoglycemic clamp, which is now a very familiar technique, in which a high-dose insulin infusion is given to lower plasma glucose. The insulin is raised very quickly in a square wave, and the subsequent hypoglycemia is controlled by measuring the plasma glucose at the bedside every 5 minutes and adjusting a glucose infusion throughout the time to control the plasma glucose so that we had it precisely under our control. And this meant we could apply the same glucose challenge to different people at different times and compare responses. So we first applied that to a group of young people with type 1 diabetes in not very good glycemic control to see what happened when they became hypoglycemic, and this shows you the adrenaline responses to that glucose challenge. They're nice and they're brisk, and they were very symptomatic. After 6 months of intensified therapy, again, as practiced in the 1980s, we were able to apply the same glucose challenge. And now, in response to the same hypoglycemia, we have a very delayed and diminished counter-regulatory stress response associated with a delayed and diminished perception of symptoms by those patients. So something had happened as a result of the way we were treating their diabetes that had caused this problem with counter-regulation to hypoglycemia. Now, about that time, I came back to the UK and worked with Edwin Gale and Ian MacDonald, and my first research fellow was Alberto Moran from Italy, and he repeated these studies in a cross-sectional way, but he added something. He added the measurement of cognitive function. And he looked at the glucose level at which cognitive function started to deteriorate, albeit in quite a subtle way, during these studies, and found that it deteriorated at the same plasma glucose, about 3 millimole per litre, in everybody, irrespective of where they started their counter-regulatory response and where they started to feel symptoms. And so effectively what we had created here was a form of what we then called hypoglycemia unawareness. And actually, again, this had been well described. R.D. Lawrence was one of the first people in the UK to receive insulin. He is the man after whom the chair that I hold is named, because when he developed diabetes, started insulin and survived, he went to King's College Hospital and started the diabetes clinic there. And he had described this change in the nervous manifestations of responses to hypoglycemia in an article in The Lancet in 1941. And many of the things he said then, we have reinvestigated and found to be true today. So what has happened? There is impairment of the counter-regulatory responses to hypoglycemia in people with insulin-deficient diabetes. Normally, you would get a good stress response starting with the diminution of endogenous insulin secretion and the secretion of pancreatic glucagon. But as soon as you start to give insulin or raise insulin with sulfonylureas, then things start to go wrong. And the first thing that happens is you lose the ability to turn the insulin off, and you also lose the ability to make glucagon in response to hypoglycemia, because the alpha cell has to see the beta cell turn off in order to function. Most people then manage very well because they get the rest of the stress response, they feel the symptoms of hypoglycemia, they eat, they prevent the glucose falling into the range associated with cognitive dysfunction. But in a certain number of people with more significant insulin deficiency, longer duration of diabetes, then problems occur in that response too, as you have seen in the study we did with Alberto. And as you lose the ability to make adrenaline and the stress response at high glucose levels, then you also lose the ability to generate and perceive symptoms, so that as the plasma glucose falls, the first thing that happens is cognitive impairment, and by the time the stress response happens, it's too weak to be effective, and you don't notice it, so you take no action. This is now referred to as impaired awareness of hypoglycemia, because there are obviously different degrees, and unawareness is perhaps a little absolute as a phrase. And it's really important, because if you look at the people, particularly with type 1 diabetes, who are experiencing severe hypoglycemia in our clinics, they are the people with hypoglycemia unawareness and impaired awareness of hypoglycemia. These are data from Ulf Pedersen Bjergaard's group. And what he has shown here in a group of British and Danish patients, with no differences between the two countries, is that if you characterize people by their awareness status, then all the severe hypoglycemia is happening in those with impaired awareness, and particularly in those where it is particularly profound. Now, they had a rather unique way of defining awareness, but Brian Freehan's group in Edinburgh have told us that about 25% of people with established type 1 and maybe about 10% of people with insulin-treated type 2 will fall into the category of hypoglycemia unaware, and that increases their risk of severe hypoglycemia six-fold if you are type 1 and 17-fold if you're type 2. Work done by Simon Heller and Phil Cryer, and then further investigated by Steve Davis, has shown us that what seems to produce these defects in counter-regulation and this problem with awareness is prior exposure to hypoglycemia. And this is a well-recognized response to a stress. If the body experiences a stress, it is likely to undergo a sort of allostatic change, whereby next time it meets that particular stress, it has a rather less vigorous stress response. And this particular example from Steve Davis shows us that if you take healthy people and expose them to half an hour or so of a plasma glucose of around 3 millimole per litre, then you impair the symptom response to a subsequent hypoglycemia. Work that was going on in the animal laboratories about the same time was starting to investigate the molecular mechanisms for that. And people like Andy McCall and Kumagai were looking at brain glucose uptake in animals exposed to hypoglycemia, either through implantation of insulinoma tissue or through recurrent insulin injections. And what they showed was an upregulation of glucose uptake, an upregulation of glucose transporters 3 and 1, the important ones in the brain, in response to hypoglycemia. And the hypothesis is that when you are exposed to hypoglycemia, you increase your glucose transporters, you increase your ability to get glucose into the brain, and next time you're hypoglycemic, you can get more glucose into the brain, and so you don't counter-regulate because the brain content still has a lot of more glucose than it otherwise would have had. Now, that didn't ring quite true to us as clinicians because we were aware that cortical dysfunction was happening, as we have shown, at around the same glucose level in everybody, irrespective of where they counter-regulated. And there were data from the animal research that suggested that whatever changes were happening were regional. These are data from Bob Sherwin's lab showing that if you made your animal hypoglycemic but maintained the glucose supply to the ventromedial hypothalamus, then the counter-regulatory response did not happen, suggesting that it was only in that area that the changes of prior exposure to hypoglycemia were happening. And people like Sanders and Ritter and various others, and Levin, have shown that there are groups of neurons through the brainstem and midbrain that are activated by hypoglycemia and will be differentially activated if there has been prior hypoglycemia. Now, these studies are a little difficult to do in man, so at this point back in the UK, we moved into functional neuroimaging. And the basis of this is that when a group of neurons are activated in a particular task, there will be a regional increase in brain glucose uptake and metabolism, which can be imaged using positron emission tomography. And there will also be a regional increase in oxygen demand, which you can either image directly or you can image the reactive hyperemia that occurs as the part of the brain becomes active and draws in more blood. And so over the next few years, I worked with Paul Marsden in the PET Centre at Guy's and St Thomas's, and with Steve Williams and Mick Brammer in the MRI unit at King's, in order to try and get some feel for what was happening to the human brain at a regional level during hypoglycemia. And the first study I want to show you was done with Joel Dunn there on the extreme left, and we used water positron emission tomography to follow the evolution of brain activation during hypoglycemia in healthy individuals. And what you can see in orange here are areas of brain that become active early in hypoglycemia, during established hypoglycemia, and then during recovery. And the blue is showing you areas that become less active during hypoglycemia or after it. Oh, that wasn't possible. So this is a list of the brain regions in yellow that become active during hypoglycemia and in blue become less active. And for those of you who are not functional neuroanatomists and are less sure, let's look at the functional anatomy of that. What you are seeing is a stress response. Indeed, you have a very beautiful, in the middle there, illustration of activation of the hypothalamic pituitary axis. If this works, I can show you that. So here, and the anterior cingulate here, which is monitoring the body's internal state. So you can see activation of brain areas involved in vigilance and arousal, usefully in feeding and the stress response, and then after the hypoglycemia, deactivation of perhaps less critically important areas of the brain involved in memory and balance, and then after the hypoglycemia, your arousal goes down and you fall asleep. So it's all very clinically relevant. What we had not expected, and what I will come back to, is that there are also changes in the responses of brain regions involved in the recognition of fearful stimuli and aversion and the reward pathways. These are all changes in activation in response to hypoglycemia, in this case in healthy individuals. Now at this point, there was a crossroads, and I had an opportunity to do something slightly different. And I was now at King's. My chair had been created by my colleague Peter Watkins at King's College London, and I had accepted that and moved into this area of southeast London. And when I looked around southeast London, it had to be said that hypoglycemia in type 1 was not our biggest problem. And so with colleagues, psychiatrist Khalida Ismail, diabetologist Steve Thomas, and general practitioner Mark Chamley, and Kirsty Winkley as our study manager, we created the South London Diabetes Study. And this was a cohort study of people with newly diagnosed type 2 in South London. The main aim of the study was to look at the impact of depression at diagnosis of type 2 diabetes on diabetes outcomes at 2 years. But what we did in doing that, creating that study, was produce a cohort of about 1,700 people with newly diagnosed type 2 diabetes in South London that we characterized very carefully and followed for 2 years. Who were they? Well, if you look at my local population, it's unusual for the UK. We have quite a significant ethnic minority population, but unlike most parts of the UK, our population is primarily Black, African and Caribbean, and 20% of our local population are of that ethnicity. What was very noticeable was that when we looked at the population of people with new onset type 2 diabetes, it was 40%, thus reflecting the extra propensity of people from the Black community to develop type 2 diabetes. When you put them into the same circumstances, the rate of diabetes development in the Black population, certainly in the UK, is exactly the same as that of the South Asians. And they were slightly different. So notably, our patients from the Black and ethnic minority community are being diagnosed with their type 2 diabetes 10 years earlier than their white peers. They are more likely to be female, but they are equally likely to be associated with obesity. So the problem for my local community is obesity and type 2 diabetes, and we therefore felt it behooved us to move our research interests to pick up questions relating to their problems. We think they may well have a different metabolic syndrome. This is a study from the SOLD database done by one of our research fellows, Cynthia Mahandas. What we noted was that although these people are being diagnosed 10 years earlier than the white population, at diagnosis, the glycated hemoglobin is worse or higher, suggesting that they have a more vigorous form of diabetes. But interestingly, by 2 years, the glycated hemoglobin is now the same and actually pretty well controlled in this population, which is primarily managed in primary care. But it is at a cost, and what we see in the Black population, particularly in those of Black West African origin, is that they're maintaining that quite good glycated hemoglobin by taking, or at least being prescribed, much more medication than in the white population. So they start with a worse HbA1c, 2 years later it's similar, but at the cost of much more medication. And Louise Goff, one of our nutritionists, had hypothesized that this was because, due to perhaps insulin resistance in the pre-diabetic state and a hyperinsulinemic state, which has been described in people of this ethnic origin, then they were becoming more rapidly insulin deficient. And indeed, our first foray into investigating this suggests that this might be the case. The red data here are from the white population. This is in response to a hypoglycemic clamp, and you can see that early in type 2 diabetes, the insulin response in the white population, whether you look at insulin itself or C-peptide, is more vigorous for the same degree of hypoglycemia than in the Black population. And there are other differences. The differences in insulin extraction by the liver, and there are some differences in the incretin response. And these are the sorts of things we would like to investigate so that we can try and more precisely tailor our medications to our patients as we go forward. Now, we haven't yet started using neuroimaging to investigate the central control of metabolism by ethnic origin. But almost by mistake, we did start to get data that were relevant to the development of insulin resistance in general. When we started to do insulin clamps in the PET scanner, one of the things that we had to address was what would the action of clamping, high-dose insulin, and glucose infusion do to our measurements of cerebral metabolic rate for glucose. And like everybody else, we found evidence to suggest that brain glucose metabolism was not insulin sensitive. So this study done by Ian Cranston and Mark Evans simply took a group of people and gave them a low-dose insulin clamp and a high-dose insulin clamp, And as you can see by the figures, whether you gave a little insulin or a lot of insulin, and therefore a little glucose or a lot of glucose, it didn't make any difference to PET-measured cerebral metabolic rate for glucose. So brain glucose metabolism is insulin independent. But then one of my colleagues pointed out that in doing these studies, we were way over the physiological range of glucose to which the brain would be exposed normally. And so we repeated the study in a different way, and this was done by Emma Bingham. And what she did was to take insulin out of the circulation with somatostatin and then replace basal insulin. So the scale for these two figures is very different. And in the pink bar, we've effectively removed circulating insulin, and in the blue bar, we've put it back to the sort of basal level you would see in a fairly insulin-resistant individual. And now you can see that there is a small but significant difference in global cerebral metabolic rate for glucose, having removed basal insulin. And if we then take that and measure it in an insulin-sensitive population, and then repeat the measurements in an insulin-resistant population, we discover that there is an impact of peripheral insulin resistance on the brain's response to insulin, in that the brain of someone with insulin resistance does appear to be insulin resistant. That, at that stage, was a novel finding and not totally expected. And we went on to look at the data to see if we discounted the global difference in glucose metabolism, we could look for regional changes in the impact of insulin, because insulin in the brain is probably acting as a neurotransmitter. And so when we look for the regional effects of basal insulin in the population as a whole, we see that insulin is driving metabolism, presumably through neuronal activation, in brain regions such as the ventral striate and the insula and the orbitofrontal cortex, and it is downregulating metabolism in brain regions such as the amygdala and the cerebellum vermis. Now, once again, what does that mean to you and me? Well, it means that insulin is driving neuronal metabolism in brain regions involved in food-seeking and reward behaviors, in the control and monitoring of taste and appetite, and in hedonic perception, the perception of pleasure. In contrast, it is actually turning off metabolism in brain regions involved in fear and vigilance and anxiety. And we found that there were differences in the impact of peripheral insulin resistance in those responses. So in the ventral striate, for example, there is an impact of insulin resistance. In the insulin-resistant subjects, insulin is less able to alter neuronal metabolism in those brain regions, whereas in the insula, there is no effect. So if you imagine a patient who is insulin resistant and therefore hyperinsulinemic, especially after eating, you can imagine that these changes might conceivably result in less satiety and more comfort on eating, and that would set you up to want to eat more to get the satiety that other people are getting and increase your comfort. So this is a small study, a very pilot study, but it is suggesting that the brain of a person with insulin resistance is hardwired to eat more than someone who is insulin sensitive. And since that study, there have been a series of investigations done by investigators across the world looking at people with obesity and with type 2 diabetes, and they do indeed have different responses to insulin, to inhaled insulin, and to food cues and eating. So if we know that obesity and type 2 diabetes alters the brain response to food and eating and the thought of food, what then becomes important is that cause or effect. And so is insulin resistance a cause of a problem that drives people to overeat and contributes to the obesity pandemic? So Yichir and Fernando Zelaya have been investigating this using a functional magnetic resonance imaging technique called arterial spin labeling, which effectively looks at changes in regional perfusion in response to whatever you make the brain do while the patient is lying in the scanner. And Yi has investigated a group of non-diabetic, non-obese, right-handed male volunteers who were either insulin sensitive or insulin resistant, but had no other pathology. And what he looked at first was their response to either a meal just before they had their scans or a glass of water. And interestingly, without all the expense and complexities of neuroimaging, we find that just by asking people questions, you can see that there are differences between the insulin-resistant and the insulin-sensitive individual in their attitudes to food and their eating behaviors. So the restraint score on the Dutch Eating Behavior Questionnaire and some of the items on the Eating Disorder Examination Questionnaire, particularly around shape and weight concern, the insulin-resistant individuals are scoring higher than the insulin-sensitive. But damn the expense, we're going to do the scans anyway. And I'm just going to show you a few snapshots of the data that Yi and Fernando have been collecting. And this is a preliminary analysis still. These studies have just been finished. These patients were either given a meal or a glass of water before they were scanned. They did 2 scans in random order. And here we see the response of the fasting cerebral blood flow change between the insulin-sensitive and insulin-resistant individuals. There is a difference in the lateral orbital frontal cortex where there is increased activity in the insulin-sensitive, and in the precuneus where it is reduced. The lateral orbital frontal cortex is our old friend that is processing the hedonic properties of food restraint, and satiation. And the precuneus is part of the default mode network, which basically turns off when you do anything else. In the fed state, so after eating, we now see differences between the insulin-sensitive and the insulin-resistant in another bit of the prefrontal cortex, which is involved in the inhibitory control of lower responses, your ability to control the fact that you might want to eat more. This is really what tells you to stop eating, and again, some further changes in parts of the default mode network. If we just look at one of these more closely, this is the lateral orbital frontal cortex, looking at the hedonic properties of food. Here you see over time the different response of perfusion in the insulin-resistant individuals in green and the insulin-sensitive in orange. And you can see that although they follow the same pattern, the insulin resistance are operating at a much higher level. When you feed them, there is a difference in that the insulin-resistant subjects now have a much more significant change in perfusion in this area, which is a surrogate for neuronal activation in this area, and now start to look like the insulin-sensitive in the fasted state. Here we're looking at a different brain area. This is the insula, which is responsible for the awareness, the body's monitoring of itself, interoception, the body perceiving how it feels. And again, you can see that there are significant differences in the fed and fasted state between the insulin-sensitive and the insulin-resistant. The insulin-resistant again in green, and they're almost swapped over, so that in feeding, there is a turning off of this brain area in insulin-sensitive, and it's turned on in the insulin-resistant in response to feeding. And again, the fed state in the insulin-resistant looks like the response to water in the insulin-sensitive, suggesting that the insulin-resistant people are having less of an ability to recognize that they've eaten and don't need to eat again. Is that due to insulin resistance? Well, as a pilot, we have tried to change the insulin sensitivity in these individuals, and he took the patients who'd done the patients, they were healthy volunteers, but people with insulin resistance who had done this study, and exposed them for 3 months of insulin sensitization using metformin and lifestyle. And after a 3-month period, he had improved their measures of insulin sensitivity, not back to normal, but a statistically significant and probably clinically significant improvement in insulin sensitivity. And he restudied them, and I'm just going to show you 2 snippets of data from that study. First of all, the satiation scores, which were slightly impaired during insulin resistance, seem to have improved back to normal, particularly in the fed state, as a result of our insulin sensitization protocol. And when we look at the brain regions that change in response to having been through insulin sensitization, then we find changes, particularly in this example, in the lateral orbital frontal cortex, again looking at the pleasure properties of food, food restraint and satiation monitoring. And what you see here is that insulin sensitization can start to move that abnormality back towards the normal response. Is that just due to insulin sensitivity, or is it a direct effect of metformin? Well, we don't know, but in this particular brain area, he has been able to draw a very strong and very nice correlation between the change in this very crude measure of insulin resistance and the change in the regional brain response in this brain region to eating. So we think we are showing that we have defects in insulin resistance that can be corrected by insulin sensitization. Again, these are non-diabetic, non-obese individuals, but they do have systemic insulin resistance. Most of them are relatives of people with type 2 diabetes, and they had abnormalities of the brain response, particularly involved in somatosensory signaling, hedonic perception, food restation, satiation processing during fasting, and changes in brain regions involved in reward processing, interoception in the fed state. These are all dopaminergic pathways, and it appears that we can make them better by insulin sensitization. Now hold that thought in your minds, because we will come back to it in a few minutes. We did also think we should look at a really successful treatment for obesity and see what that did to the central control of appetite. And these studies are using glucose positron emission tomography done by Kate Hunt and Joel Dunn. This slide is from the Swedish obesity study, showing you that one of the most effective lasting treatments for severe obesity is, as you all know, the Roux-en-Y gastric bypass. And so Kate decided to look at what those patients' brains were doing in response to food. And at the end of PET studies done in the fed and fasted state in her patients, she also gave them an ad libitum meal. And what you see here is that there is a small reduction in the amount people want to eat, having had a test meal as part of their scan. That's the solid bars compared to the hatch bars. In normal weight individuals with normal insulin sensitivity, in obese insulin sensitive individuals, but the big change is obviously after Roux-en-Y gastric bypass. And just for fun, she repeated the study in the gastric bypass patients with somatostatin to see what happened if she took out the incretin and insulin responses. Again, I'm not going to show you a vast number of neuroimaging details, but just some key points from that study. These scans these are statistical maps that show you brain regions where the response to food ingestion differs between these three groups of subjects, the hypothalamus and pituitary, and some of the regions we've been talking about before, the dorsolateral frontal cortex and the medial orbital frontal cortex. In the hypothalamus and pituitary involved in energy balance, you can see, comparing the open bars with the black bars, that the Roux-en-Y patients actually have an abnormality, an exaggeration of the normal response to food, which is not impacted on by somatostatin. But in the dorsolateral frontal cortex involved in inhibitory control, there is in fact an abnormality in obesity that is corrected by bypass, again not affected by somatostatin. But in the brain pathways involved in reward salience, Roux-en-Y actually creates an abnormal response that is associated with this loss of appetite that the patients feel after their surgery, and this is the one thing that does appear to be mediated either through incretins or insulin. Most recently, we've been looking at non-surgical interventions. This is a duodenal exclusion device. It's a plastic tube that is inserted into the duodenum to separate the food flow from the duodenal lining. This was done by Pearson Gupta with the principal investigator, Bob Ryder from Birmingham. We haven't done neuroimaging in these patients, but this is just to show you that in a study where we looked at adding this device to the GLP-1 receptor analog liraglutide in patients who'd failed to get control on liraglutide, we do see a very good improvement in weight over 12 months that the device was in situ, with both the endobarrier alone or with the GLP-1 receptor analog, and a very good improvement in HbA1c, particularly in the patients who continued to get the receptor analog with or without the duodenal exclusion device. And the reason for mentioning this is because what was clear with these patients was the change in behavior that lasted only as long as the endobarrier was in situ. They ate differently and they exercised differently. And as soon as the device was out, anecdotally, they went back to normal. They also had a significant improvement in hepatic steatosis. Throughout all this, we hadn't forgotten our sweet and low hypoglycemia problem. And we had been demonstrating, and again this study was done by Ian Cranston, that while you could induce counter-regulatory deficit and hypoglycemia problems by exposure to hypoglycemia, so too could you restore counter-regulatory deficit and hypoglycemia awareness by hypoglycemia avoidance. Ian here has taken a group of people with hypoglycemia unawareness, people with type 1 diabetes and hypoglycemia unawareness. He found a very pathetic, weak symptomatic response to the hypoglycemic challenge when they entered the study. 3 months after avoiding, as far as we could tell, all exposure to a plasma glucose of 3 millimole per liter or less, he had restored their counter-regulatory response to normal. And that was in everybody, tightly controlled or not tightly controlled. They went from being unaware to hypo-aware by avoidance of hypoglycemia. Sadly, outside the study, they could not maintain those behaviors. But while we were doing that, and during the DCCT, in Dusseldorf, Michael Berger and his team were showing that they could take large groups of people with type 1 diabetes and apply an intervention at year 0 that both reduced HbA1c and at the same time lowered the risk of severe hypoglycemia, shown in blue there. What he was doing was teaching them how to use insulin flexibly using a structured education program that just taught them how to use insulin themselves rather than left them dependent on healthcare professional advice. What he had done, effectively, was to take the DCCT data and turn the hypoglycemia relationship around. So with Simon Heller and Sue Roberts, we went to Dusseldorf to find out what they were doing. My nurse colleagues, Eileen Turner and Helen Rogers, were the King's contingent of this. And between us, we brought back that German program, translated into English, into something we call DAPHNE, Dose Adjustment for Normal Eating. All we did was translate the language and the food plates, because the British eat very differently from the Germans. And we ran a randomized controlled trial of that educational intervention in people with type 1 in the UK, and then rolled it out across the UK. There are now nearly 40,000 DAPHNE graduates in the UK. And an audit of that service shows that we more than halve, nearly down by two-thirds, the severe hypoglycemia rate in our patients. And of people coming to the program with impaired awareness of their hypoglycemia, 43% of them are hypoglycemia aware a year later. We've since done a meta-analysis of structured education programs in flexible insulin therapy. Some of these are hypoglycemia specific, some of them aren't. But basically, if you teach patients how to use insulin flexibly and use it themselves, then you can stop their severe or significantly reduce their severe hypoglycemia as well as improve their HbA1c. And in the DAPHNE study, we were able to show that that's accompanied by restoration of hypoglycemia awareness. We assume that's because they are experiencing less hypoglycemia in their daily lives. And so now we are able to offer our patients with hypoglycemia problems a pathway of care, because in addition to this evidence, we have the evidence for the benefits of technology such as pumps and sensors in hypoglycemia prevention. Interestingly, not in hypoglycemia awareness. And we now have a care pathway that seems to work. So somebody comes to us with a hypoglycemia problem, we review their use of insulin, and if necessary, we offer them retraining in structured, inflexible insulin therapy. And as you've seen, the severe hypoglycemia rates improve, and hypoglycemia awareness is restored in just under half of the people who are bothered by it. For those people who don't achieve their required goals with this sort of therapy, then we move them to insulin pump therapy. John Pickup's data would show that that's associated with a 4-fold reduction in severe hypoglycemia risk if you apply it to people who have severe hypoglycemia problems. And the use of CGM with or without the pump therapy in people with severe hypoglycemia has been shown to reduce severe hypoglycemia very significantly, not by restoring awareness so much as by replacing endogenous awareness with electronic awareness. And for people who really still can't hack it, as our chairman has indicated, we have now got transplantation therapies to offer them. But the question remains, what is it about those people who don't succeed with this pathway? Because the majority of people will do very well if they follow this pathway through. But there are some people who either can't or won't engage with it. Does it work? Well, yes, it does. These data are from my colleague Pratik Chowdhury and our liver transplant team with whom we do our transplant program, Nigel Heaton and Guachai Wang. We just audited, one of our medical students, in fact, Megan Byrne, audited 45 people who came to us for islet transplantation because they had the UK criteria of more than one severe hypoglycemia a year for no particularly good reason. The first thing to note is that this hypoglycemia is a marker of poor health, and 3 of these patients died before they could progress along our pathway, not from hypoglycemia, but from cancer and cardiovascular death. 4 of them were discharged because all we had to do was tell them how to use their insulin properly. But the remaining 36 came to our pathway and went through it, and the results were as follows. About half of them resolved completely, having gone through the pathway I've just shown you. 10 progressed to transplantation, and at the time of the audit, 9 are still in medical therapy. The 17 who resolved, 13 complete resolution with no severe hypoglycemia, 4 with only 1, and they did it through insulin dose adjustment, retraining in insulin therapy, pumps and sensors. The 9 who are still in medical therapy are doing quite well. That shows you their change in severe hypoglycemia rate. It just hasn't come down quite enough to make them ineligible to proceed to transplantation. But the question remains, what is it that's stopping some of our patients from succeeding? And for this, we come back to our neuroimaging, and here we have looked at the difference in the brain's response to hypoglycemia between people who are hypoglycemia unaware and people who are hypoglycemia aware. And what you see here is that in brain regions involved in the stress responses and the emotional salience of stress, here you have a brisk response in your healthy volunteers in blue, your hypo-aware in red, and no response in your hypo-unaware in green. But if you look at the brain responses involved in reward and hedonic perception, the perception of pleasure, which is turned off in healthy volunteers or hypo-aware individuals, look what happens in the hypo-unaware. It certainly isn't turned off, and it appears to be stimulated. These people are getting no message that hypoglycemia is bad for them, and that may be why you cannot engage them in strategies to avoid it. One of our other medical students, Charlotte Smith, looked at the amount of advice our patients took when they came to our clinic about how to adjust their insulin by hypoglycemia awareness status. Slightly to our surprise, our hypo-aware patients accept about 80%, 90% of our advice. Our hypo-unaware patients about 40 to 50%. And Helen Rogers went and talked to our unaware patients in a structured way to find out what they were thinking, and of 17 patients she spoke to, only 4 really expressed concern about their hypoglycemia. The others all had different ways of normalizing the hypoglycemia as part of their daily lives. Linda Gondra-Frederick has looked at a much bigger clinic population and finds a similar division of people into different categories. People at low risk for hypoglycemia who are very concerned, people at high risk who are high concerned, who presumably will do quite well with better technology, people who have neither risk nor concern, which is fine, and a small group, about 8 to 10% of people who have high risk and low concern, and we believe those are the people that you cannot stop having hypoglycemia despite all our education and all our technologies. And for those, with Nicole de Soyser, a clinical psychologist, we developed a program that we call Daphne Heart because we used it in our Daphne program, and Heart stands for Hypoglycemia Awareness Restoration Training. And essentially it's the use of psychological techniques, cognitive behavioral therapy, motivational enhancement, the sorts of therapies you use for people who persistently do things that you and they know are bad for them. And it's a group course. It spreads itself over 6 weeks, and it particularly tackles some of the motivational and cognitive barriers to hypoglycemia avoidance in patients with type 1 diabetes and resistant impaired awareness of hypoglycemia. What did the patients tell us? Well, there was a feeling that everything has to be normal. And so these patients were unable to stop behaviors that tried to get their blood glucoses super normal. Their glucose targets would be too low. They'd be forever correcting their slightly high blood glucoses, particularly after meals and after hypoglycemia, and they could not stop doing it. They didn't want to make a fuss. They thought it would never happen to them again, even though it had happened several times before. But one of the particularly important things was an acceptance of it's part of my diabetes and a belief not just by our patients, but also by us, the healthcare professionals, that it can't be fixed. What happened? Well, with this 6-week psychological intervention, and this is just a pilot run with King's and with some patients in Sheffield under the care of Professor Simon Heller, we showed that 12 months after this intervention, people who for years had been coming to the clinic with hypoglycemia problems, suddenly the severe hypoglycemia had gone, moderate hypoglycemia was much better, and the sorts of behaviors they had changed were the sorts of things we'd been talking to them about changing for the last 10 or 15 years. This is just a pilot, but it certainly seems to have worked. So to summarize, and if I may speculate a little, hypoglycemia, which I have been working with my patients for a long time now, is a common event in the treatment of diabetes, and exposure to hypoglycemia leads to reduced awareness and loss of protection from severe episodes. But it can be treated, and we have to believe that because otherwise our patients won't believe it. So the cognitive barriers in our patients and in us need to be overcome to engage us and our people with diabetes and impaired awareness in prevention strategies. And the other thing that I would like to speculate is that given the similarities in the neuroimaging, the brain's response to hypoglycemia and the hypo-unaware, the brain's response to food cues in the insulin resistance, it's nice to believe that education alone will not solve the obesity pandemic. We know that. There isn't a patient out there who doesn't know that they shouldn't eat more healthily and exercise more. And I think we're going to need to supplement those educational efforts with psychological therapies if we're going to defeat diabetes. I obviously didn't travel this road on my own. I've had a lot of support, a lot of friendship, and a lot of help over the years. And I'd like to finish off just by acknowledging my mentors, particularly Harry Keane, Arnold Bloom, Bob Sherwin, Bill Tamerlane, Ralph DeFronzo, and Edwin Gale. The collaborators I've had throughout the years of my research, the wonderful people, the nurses, research fellows, and technicians who've worked on all these projects and done the work that allows me to give talks like this, the people who've trusted me with their money to see if we can investigate these things, and most particularly the people with diabetes, the people at risk for diabetes, and their families who have involved themselves in this research in the hope that they can help themselves and actually others. And I'd also like to thank my clinical colleagues at King's who look after our patients, and as a team with the patients with diabetes, we hope we can make things better for people with diabetes in the future. I'd like to thank you for listening and the IDF for giving me this fantastic opportunity of reviewing what I've been doing over the last many years. Thank you very much.
Stephanie, thank you for an absolutely wonderful lecture. We have time for a couple of questions if there's anybody who wants to ask a question. If you do, please come to a microphone and say who you are and where you come from. At microphone number 3.
Yes, hi. Danielle Paco from Calgary. I'm one of the pediatric endocrinologists there. I wonder if you could, if you have any insight on those families, I'm talking about families because of the kids, but on those individuals who come to our clinic and they've had years of having almost daily mild hypoglycemia, but yet they've never had a severe hypoglycemia, and they have great A1Cs, obviously, yep. But we keep on kind of warning them that this may be an issue, yep. And some of them even have recognized hypoglycemia and awareness, but it's hard for them to recognize that the number of those they're having may be problematic. Are we wrong by saying that it's problematic then?
So I think that's a really good question, because certainly in adult diabetes, we do see that. Not commonly, but occasionally you have someone who comes up with the record book and there are quite a lot of hypoglycemic episodes and they've never had a severe hypo. And there is some evidence that the sorts of changes we are seeing may be pre-programmed, and that some people actually do respond the way I've described, and maybe some people don't. And there is also some evidence that there are some genetic changes that make you more prone to cognitive dysfunction during hypoglycemia. So I think it is possible that there are a small group of people who are protected from this cycle of hypoglycemia unawareness begetting more problems. The problem is we don't know that, so I think we still have to be cautious with our patients because, of course, the first really severe hypo could be the first severe hypo. But I think where it's been going on for a very long time, certainly in adults, I back off a little, but very, very cautiously. So I think there are questions we don't know. I recognize what you're describing. I'm not prepared to generalize it yet.
Thank you.
So we take two more questions at mic number 1 and then mic number 2.
Thank you. That was wonderful. Irene Haramiak from Canada. So I have a question about our patients who are type 1 diabetics. Do they learn, or are the brain functions there intrinsically and they develop type 1 diabetes? So that small group of people who have recurrent severe lows and have that hedonistic response.
Yep.
Do you have a speculation about that or any evidence?
So I do have a speculation. In a sense, it relates to the previous question.
Right.
I think it is possible that people are pre-programmed to respond in that way, and it just happens to be they got diabetes and hypoglycemia is the stress to which they're responding. And indeed, a mother of somebody with hypoglycemia unawareness, when I'd given a talk to a lay group, came up to me and said, I know exactly what you're talking about. And she used the word I'd never dared use in public. She said, my son has an addictive personality. I don't know, but we may be able to answer that question because now that we can use MRI to look at this rather than PET, we are in the middle of a study to look at how much of the brain response to hypoglycemia is reversible. So we can't study everybody and then see what happens over 15 years, but we've taken a group of people with hypo-unawareness, we're measuring their brain responses to hypoglycemia, and then we are working with them to reverse the unawareness, and then we will rescan them. And if they change back to normal, then I can answer your question. But it is possible, I think, that some people are programmed to respond to stress in this way more vigorously than others.
Thank you.
Hi, Colleen from Canada. I have a question for you. One of our barriers to getting good glycemic control in our patients is getting their numbers low enough. But a lot of people complain that they feel low blood sugars between 5 and 8. You know,
Yep.
For me, my blood sugar is low at 8. No, not for me personally, but that's what a patient would say. So I'm wondering what's actually happening in the body. Does the brain have a higher threshold for glucose when their sugars are higher? Or?
Yes, it does. And we have shown that. I did a study with Andrew Hatter's group in Exeter where we looked at people with type 2 on the basis that type 2 with a slightly high HbA1c probably haven't seen hypoglycemia, unlike many type 1s. And indeed, even if you take glucose up a little bit and then bring it down, people who are accustomed to a higher blood glucose will start to counter-regulate at a higher than normal blood glucose. What doesn't happen, at least in our hands, is an upregulation of the glucose at which cognitive dysfunction starts. So they're quite right. They are feeling symptoms at a higher glucose level, and all you can do with them is take them slowly through it and encourage them to hang on and delay treatment and then get used to it. And that can happen quite quickly. But it's presumably the opposite of what we're describing. The brain gets used to a low blood glucose in terms of glucose sensing and mounting its stress response, and it presumably does the same thing in the opposite direction if it's always used to something high. So I think they're describing something quite real.
Thank you.
All right, thank you again, Stephanie, very much for an
Thank you.
outstanding lecture. May I remind those of you who are